Hello, good evening, everyone. Uh, I'll ask Samir to start off today's class on post-operative complications and surgeries for carcinoma esophagus.
Which
Samir?
means to say you have already discussed about the surgical approaches.
ಇಲ್ಲ
ಇಲ್ಲ ಅದೇ surgery and post-op complications.
Okay, get going. Yeah.
Okay.
Sameer.
Sameer. Sameer, are you there?
Yes, sir, one second.
While he is logging in, can somebody tell me what are the basic principles when you are dealing with carcinoma in the intestines? What is the minimum margin required?
Anybody? Nikita?
Sir, intestine-wise, any intestine minimum margin required would be 5 centimeters, sir. But in case of low anorectal carcinomas, 2 centimeters is also acceptable.
Okay.
In view of sphincter preservation, sir. Otherwise, 5 is usual.
So
margin.
when it comes to esophagus, what is the margin? That is the lengthwise that you are saying. Circumferential?
Not only sphincter preservation. The spread is usually said it is in an upward direction.
So 1 centimeter now.
The lower Nikita, 1 centimeter margin is sufficient.
Nikita, 1 centimeter is sufficient. Circumferential resection margin should be more than 1 millimeter. Ideally 3 millimeters, but definitely 1 millimeter.
Yes, sir.
Have you discussed these principles in relation to esophagus in the last class?
ಆ level ಹೋಗೇ ಇಲ್ಲ.
Okay. That's what decides what approach you take for esophageal carcinoma, depending on where the tumor is.
Start from indications.
Yeah.
I'll start, sir.
Yeah, please.
Yes. So we'll continue from the esophageal carcinoma, the approaches to esophageal carcinoma. So first one is the transhiatal approach. The transhiatal approach, in which patient will be made in a supine position. There will be a midline laparotomy done to mobilize the stomach, wherein we will divide the short gastric and short gastric vessels, preserving the gastroepiploic artery, which will be the main arterial supply. Then we'll do the pyloromyotomy. The second phase will be. It is not. The second phase will be we will widen the hiatus, by dividing the anterior crus of esophageal hiatus. Then the surgeon's hand will actually mobilize the esophagus through blunt dissection between the esophagus and mediastinum, where there will be the avascular plane, and finally there will be a cervical incision made, before which we have to do a gastric conduit by linear stapling the stomach, and this will be pulled through the posterior mediastinum up to the cervical incision, and there will be, in the cervical incision we will do the gastric anastomosis.
So what are the three major procedures, man? One
Sir,
is
transhiatal, one is Ivor Lewis, and third will be McEwen, sir.
McEwen's 3-stage, Ivor Lewis is 2-stage.
Yeah. Yes, sir. Yes, sir.
Why did you start with transhiatal esophagectomy, Sameer?
Sir, from the distal esophagus, I am going up, sir. That.
Okay, so what are the indications for transhiatal esophagectomy?
Which is the commonly performed procedure?
So it will be distal esophagus and G junction early stage tumors. We can go for transhiatal, sir.
Okay.
Yes.
Can you do anything less than transhiatal? Can you anastomose in the chest itself for these tumors, lower esophageal tumors?
Only just.
Yeah, that is Ivor Lewis, man.
You need a margin of about 5 to 8 centimeters or maybe 10 centimeters. If it's a lower esophageal tumor, you will get the enough margin and then you can still anastomose in the chest itself, isn't it?
Yes, sir.
That's what Ravi Shankar said the name for it. What is it?
Ivor Lewis.
Then why are we doing transhiatal for this patient?
You are telling the early stage. Transcendental is a palliative procedure.
You are already getting there, point there. Go on.
What is transhiatal called, man?
Pull through, sir.
No, it's called Oringer surgery, Oringer's operation. So, as Shrikant said, transhiatal was usually considered as a palliative procedure when you couldn't do a definitive procedure for with curative intent. But nowadays, I think with advent of neoadjuvant chemoradiation and other things, it is no longer just a palliative procedure. It can be considered as a curative operation as well. What is the current gold standard for all esophageal surgeries, man?
Okay, let him just
Sir,
present what
gold
he
standard
has
in
PPT, then we will
means
Okay.
discuss. I think he is getting
Okay.
confused. Yeah.
Okay, present.
Continue with your presentation. At the end, we will discuss.
yes, sir.
Samir, all these questions are coming because you're not approaching like this thing. You're going procedure wise. So if you understood, you would have been able to answer. Anyway, go ahead. Go ahead. We'll see.
Sir, then we have the Ivor Lewis two-staged approach. This is mainly indicated for mid and distal thoracic esophageal tumors. Here we have both abdominal phase and right thoracic phase. In abdominal phase, via laparotomy or laparoscopy, same the gastric mobilization, celiac lymphadenectomy, and a creation of gastric conduit will be made with optional pyloroplasty. In stage 2, a right posterolateral thoracotomy or thoracoscopic approach will be made, and the thoracic esophagus will be mobilized with appropriate mediastinal lymphadenectomy and division of proximal esophagus. Finally, the reconstruction of intrathoracic esophagogastric anastomosis will be done with a chest drain placement.
Go on.
Yes. And this is the McKeown three-staged approach in which we have a abdominal, right thoracic, and a cervical approach. This is mainly for upper and mid thoracic tumors. The same abdominal and right thoracic steps are same, and we have a cervical step wherein the pull-up of gastric conduit will be made and cervical anastomosis is done. Cervical anastomosis is safer because there won't be any leak and in the thorax.
No.
Sir.
There won't be any leak, Allah. The leak is contained.
Leak rates are lesser, and like even if it leaks, the complications are lesser. In that also there will be leaks.
Yes, sir.
Okay, hold on. When you said it's a 3-stage esophagectomy, which stage 1, what surgery are you doing?
Stage 1 will be abdominal, sir. Stage 2 will be
Tumor is in the mid esophagus, in and around the heart, azygous vein, hilum of the lung, trachea. So which step will you do? What will you do in stage 1?
Sir, first gastric mobilization has to be done to make the conduit.
That is Ivor
No,
Lewis.
man. Understand. What is sir's question?
What you said is correct for the Ivor Lewis. First abdomen, then the chest. But in a patient with a tumor in the mid esophagus, which surgery will you do first? I can't give you a clue better than this.
Mid esophagus, we have to go thoracic approach. I'll do first.
Yeah, anybody else, Nikita? Which stage or which operation will you do first?
Sir, cervical would be first, sir.
Hey, Nimajin in class in the
Nikita,
ಓಡಿಸ್ಬಿಡ್ತೀನಿ.
you'll fail.
ಬೆಂಗಳೂರಿಂದ ಓಡಿಸ್ಬಿಡ್ತೀನಿ.
Sir.
Tumor is in the mid esophagus. You are doing a 3-stage esophagectomy. Whether you do laparotomy, thoracotomy, or the neck first. Do you want to see whether the tumor is resectable or not?
Nikita, this
Yes,
is
sir.
common sense, no? How can you say neck
Thoracoscopy we
first?
do, sir.
Thoracoscopy or
Any
thoracotomy.
approach,
Thoracic
thoracotomy,
approach is the first
thoracoscopy,
one.
doesn't matter. Approaches doesn't matter. It is common sense, no? When you need to see whether you can operate or not. If everything is infiltrating, if you do cervical or if you do abdomen, and the tumor is stuck, what will you do next? You cut off the stomach, you cut off the neck, this thing also.
That is a question at MCH level. In case you have done, like you said, you have done it and then tumor is stuck to heart chambers and you cannot resect. Okay, now you tell me, what will you do? Tumor is stuck, you cannot resect. But you have already done the irreversible step of mobilizing the stomach, making a gastric conduit. What will you do next? How do you relieve the dysphagia?
Come on, man. Somewhere it's very simple.
Can transhiatal approach, sir, like palliative we have discussed
No.
there.
Transhiatal tumor is stuck. Tumor is stuck and unresectable. You have to leave behind that part of the esophagus in the mediastinum, and you have to bring the already mobilized gastric conduit into anastomose into the esophagus. Which route will you take now?
Come on, Nikita, or anybody else can, you not Sameer, not only Sameer, and others also can answer.
Who are the final
What
years?
other
Retrosternal we
approach is
can do,
there?
sir. Retrosternal.
If in the corrosive esophageal stricture, where will you bring the conduit to anastomose? Corrosive esophageal stricture, where the you leave behind the mediastinal esophagus. You mobilize the stomach or colon and bring it up and anastomose to the cervical esophagus. Which route will you take? Where is the conduit?
Uh,
Anterior mediastinum, subcutaneous, retrosternal. Where is it?
Anterior mediastinal, sir.
Just beneath the
Sir,
sternum, I say. Yeah.
Yeah.
retrosternal, yes, sir.
Yeah, correct.
I had mentioned retrosternal just again, sir.
Posterior mediastinum, you said, not anterior.
No, retrosternal, I told, sir. Yes.
Okay.
So,
Classical
yes.
McEwen 3-stage. It is the chest first, and then the abdomen, and then the neck.
Neck.
Okay, continue. Yeah.
Okay. Sameer.
Continue.
Yes, sir.
Sameer.
Yes, sir.
Now, just the main procedure is the thoracic procedure. So, explain to us the steps of esophagectomy. How do you start? What do you do? Not read it.
Do you know the blood supply of different levels of esophagus?
What are the important structures that you need to look for and preserve? What is that you can sort of ligate and so you should, the important steps you should know. Nikita or Sanya, anybody?
If it is thoracotomy, how will you do? If it is thoracoscopy, how will you position the patient? And which side you approach?
Left or the right? There are only two, man.
Right thoracic, right thoracic.
Yeah, correct. Yeah.
So what are the main steps? What is the first step that you do, which can cause significant bleeding if you don't do it?
Tumor is in and around the atrium, azygous vein, SVC, lower trachea. So what will you do to see whether to mobilize the tumor?
Yeah, have you read the procedures, man?
ಯಾರು ಓದೇ ಇಲ್ಲ, ಸುಮ್ಮನೆ ಏನೋ
ಮತ್ತೆ
ಬಂದ್ಬಿಟ್ಟಿದ್ದಾರೆ.
ನೀವು ಬರೀ ಕನ್ಸಲ್ಟೆಂಟ್ಸ್ ಆರ್ ಟಾಕಿಂಗ್.
ಅದೇ ನಿಖಿತಾ,
have you read the procedures, all three procedures?
Nikita, come on, explain.
Yes, sir.
Explain what is the thoracic procedure.
Time we postponed for one reason for postponing it was for preparing also, no, Sameer? Nikita, explain.
Sir, if it is a thoracic approach, like thoracic is phase 1, then after the thoracoscopy and confirming that, we divide the pulmonary ligaments first, sir. Then
No,
enter into
whether
the
you are doing a thoracic approach or open approach.
sir,
Whether you do
procedure required
thoracoscopy or
for
thoracotomy doesn't matter, but the steps have to remain the same. What
Where
inside
is the
have to
incision?
remain the same. Yeah,
Which costal,
continue.
Yes, sir.
which intercostal space you make the incision?
Sir, 7th intercostal space, sir.
Classical thoracotomy is made through which intercostal space, ma?
Allinda you start from there.
So you want to go high also, no? You have to have control over a lot of vessels and everything. So if you go at 7th, you will not be able to do that.
Where do you put the incision? What are the structures you encounter?
Fifth intercostal space, yes.
5th intercostal space. First we
What
put
are
a
the
port
structures
and
you encounter?
After confirming resectability, what will you do first?
sir, we divide the inferior pulmonary ligaments, sir, to separate the compress the lungs and deflate the lungs and separate the pleura. We divide the inferior pulmonary ligament.
Okay.
And enter into the mediastinum.
Okay.
And first we start to dissect from the distal esophagus upwards, sir, cranially.
Yeah.
And then you make the distal esophagus avascular and necrose if the tumor is stuck and it is unresectable. Is that what you are saying? You start dissecting from the lower esophagus, you have mobilized lower esophagus up to the tumor, and then you find the tumor is stuck or infiltrating and unresectable. So you have made the distal esophagus avascular, leading to necrosis.
So that means
is that the correct step?
We have confirmed. Got it, sir. First, the tumor portion has to be mobilized. This is what you are focusing on.
No,
Ravi Shankar specifically.
Whatever the tumor portion.
Yeah.
Yes, sir.
In the narrow space in the posterior mediastinum, you have to ligate the which vein?
First thing you have to do is to do that.
Esophagus.
Correct. You have to ligate that because tumor is there in the mid esophagus. And then mobilize the tumor. Make sure that you can take out the tumor. Then you mobilize the proximal and distal esophagus. Proximally up to the root of the neck, distally up to the hiatus. And then make sure you harvest as many lymph nodes, subcarinal, pre and paratracheal lymph nodes having gone into the chest. That's the disadvantage of transhiatal because you cannot harvest the mediastinal lymph nodes, just lymph nodes.
Yes, sir.
Okay, Sameer, 3 different conduits you have shown. When will you use and what will you, how will you decide?
For conduit, sir, the best will be stomach, sir, because it will have the proper this vascular supply and it can reach up to the neck. And but if at all we don't have it, because of previous surgeries or we are resecting the stomach itself.
So
reaching up to the neck.
Yeah.
Okay. The main thing is when will the stomach not be available for you? So that is when you have to use jejunum or colon. When will the stomach not be available? Which condition?
Sir, if the tumor is already spread to
not tumor, it is never in the tumor situation. It is something else.
I've already said it before.
Caustic injuries.
Corrosive structures. See, there will also be concomitant stomach, significant portion of stomach injury will also be there. And the stomach will also be very cicatrized and fibrosed, and it's when it will be no longer functional. So you may not get the stomach as a tube. So then you consider using either jejunum or the colon. Which colon do you use usually?
Right side or left side will you use?
Right colon.
Yeah, okay, right colon. Okay, he seems to have not read. Okay, jejunal flap, come. What have you depicted in that picture? Some vascular anastomosis. What is it? In the
Sir,
top right corner picture, you have shown jejunal flap and then you have shown some
yes,
vascular
sir. Sir,
anastomosis
these
in
are
an artery. What is it?
sir, these are this supercharged microvascular
What do you call
like
when you use vascular anastomosis? Hmm.
pediculated flaps.
Yeah, okay. Hmm.
So basically, it is a free jejunal flap.
Okay.
Yes. The second best option will be colon, but um, it will have higher morbidity and will require uh, more anastomosis. Three more anastomosis.
Even if you use jejunum, you have to do additional anastomosis, isn't it? Like
Yes,
you
sir.
do it in when you use a colonic conduit. You avoid those two anastomosis by if you are using a gastric conduit only.
Only single anastomosis. Yes.
Yeah.
No,
That
you said high
increases.
morbidity. No. What is that high morbidity? You're generally telling or you know about it? Compared to jejunum, what is that high morbidity?
Okay, let him complete the presentation. We are stuck in this
Okay.
second slide itself. Complete. Okay, go ahead. Yeah. Continue, Samir.
Yes, sir. Uh, then for lymph nodes, we have a standard lymph node dissection, extended, and the three-field lymph node dissection. The two-field is what which is practiced in Western countries, and three-field in the Japan. So, three-field lymph node dissection will yield a higher lymph node clearance, and
First,
patient
tell me
can.
what do you mean by two field? What do you mean by three field?
It's very simple, man. Come on.
You are presenting, Samir. You are using the terminology. You must know what do you mean by that.
It's not just the
If
number.
you're not read, you will like how will you teach everyone then if you are not prepared? If you whatever you put up, you should be knowing, no? You're using two field, three field.
And it is depicted there in the picture.
Nicely.
So, two-field will be around this thoracic and abdominal, sir, and three-field will be thorax, no abdomen, and neck lymph nodes.
Lower neck lymph nodes. When you say thoracic, you need to specify which group of lymph nodes will you take. When you say abdomen, which group of lymph nodes will you take? Are you going to harvest the lymph nodes along the pelvic lymph nodes? Along the IVC? Which lymph node? Specifically, you have to say.
Celiac.
Sir, it is paraesophageal, subcarinal, and main bronchus, and posterior mediastinal lymph nodes in thoracic, and
And
abdominal lymph nodes.
paratracheal lymph nodes. Okay,
Yes,
in the chest. In the
abdomen
abdomen,
abdomen will be right and left the cardiac lymph nodes and lymph nodes along the vasculature, sir. That will be lesser curvature, left gastric and common hepatic artery and celiac artery.
Okay, continue. Yeah.
Cervical lymph nodes will be cervical paraesophageal and um, supraclavicular lymph nodes.
Okay.
So three-field lymph node dissection, although it has a higher clearance and survival, but it is associated with a higher rate of recurrent laryngeal nerve injury.
So what is the basis of using 3-field versus 2-field?
If it has higher complication rate, why do the Japanese practice 3-field lymphadenectomy? What are you gaining by doing it? Spending more time, taking more risk.
Sameer,
So
if you go back,
disease-free survival is
if you go back to the anatomy of esophagus, the lymphatic supply of esophagus, you will be able to answer this question.
sir, both disease like the 5-year survival rates and
No, those are all corollaries, man. The basis is the extensive lymphatic network of the esophagus causes a third of lower esophageal tumors to have spread to cervical esophagus and vice versa. So, which is why when you do a 3-stage esophagectomy, you also include cervical nodal dissection, so that you are ensuring that you are removing more lymph nodes, so that you are achieving more local disease control.
Okay, good. He answered it. Next.
uh, then a short here on robotic assisted minimally invasive esophagectomy. The principles are same and it has a technical advantage
Hey,
because
you
we'll have
complete this, man, first. After mobilization, what is the resection? How do you anastomose? All those things.
What is the usual esophagogastric anastomosis? How many layers do you do?
How many layers you use? Where will be the anastomosis?
How will you identify cervical esophagus? What is the danger when you are trying to dissect it out? What nerve is there, man, while you are trying to dissect it?
recurrent laryngeal nerves.
Correct. So,
Yes.
and what other structure can be there which can cause a significant
Thoracic duct, sir.
correct. So thoracic duct. So you have to avoid injury to all of that and identify the esophagus cervically, and then what is the anastomosis
The
usually
anastomosis
between
will be
stomach?
uh,
How many layers?
2 layers, sir.
What are the two
It will
layers?
be seromuscular to muscular layer of in the posterior posterior is a layer, and then
So that is one layer only. Whether it is posterior, anterior, doesn't matter. But if you are saying two layers, which are the two layers? Nikita, anybody else?
Sir, mucosa to mucosa, and second is seromuscular, sir.
Commonly done is a single layer anastomosis. Yeah, you can do a 2-layer anastomosis. There is nothing wrong in it, but commonly done is a single layer anastomosis.
See, the problem with esophagus is it doesn't have a serosa. So, interrupted.
I was about to ask the question, which layer is absent? How can you do seromuscular?
Correct. So, you have to do
Serosa of gastric.
interrupted. You have to do an interrupted, this one, a single layer, probably through and through.
Will you do pyloroplasty or not? Will you do feeding jejunostomy or not? There are additional procedures that you have to debate at this stage before
Yeah,
proceeding to robotics.
yeah. When will you
What is
do?
the scientific evidence to do or not to do pyloroplasty?
Sir,
What
because
is the debate about feeding jejunostomy?
we are dividing the vagus, so there will be pylorus will go into spasm.
No, no.
Mhm.
So
If you divide the nerve, you go into spasm or paralysis.
Gastroparesis, man.
Dilatation, like
Gastric emptying. Gastric
relaxation,
emptying. Gastric emptying will be
sir,
affected. So that is why
increased.
you. So basically, what you have to do is to disable the sphincter.
Is there a debate whether it is accepted universally that you should do it, or some people say that I don't do it and my patients do well? What is the scientific evidence?
Now they're saying that there is no difference, sir, in
Correct.
terms of doing pyloroplasty or not doing it.
Hmm. Yeah,
So,
correct. You're right.
so
There,
like some people, like it depends, like surgeons' preferences. Some are
Yeah,
preferring it and some are not, sir.
correct. But there is no hard evidence to say that you must do it.
there are people who just put while they are creating the stomach tube, they just put a sponge holder and just gently dilate the pylorus rather than doing a formal pyloroplasty also. And it's again surgeon's preference. As Rajshekhar said, no hard evidence to suggest one way or the other.
Now is the question, will you do a feeding jejunostomy or not? If you're not doing it,
Why
what are
not?
the risks involved if you do it and if you don't do it? Why does he need a feeding jejunostomy?
sir, we have to give him like enteral nutrition.
Okay.
So yes, and to protect the anastomotic site.
What is the basis for doing a jejunostomy, man? First of all, see if you lead
Sir,
it in the right
adequate
way.
nutrition.
No,
Sir,
that is nutrition is obvious, but why? Why nutrition? See, patients with CA esophagus, cancer cachexia, dysphagia, they will not have eaten for a long time. So there would be significant weight loss preoperatively. And usually you may not have the opportunity to feed them before surgery. So these people are nutritionally depleted and hence you want to start nutrition immediately. So you give them a feeding jejunostomy and irrespective of your anastomosis, you can keep feeding these patients. Once you are sure about your anastomosis, you can then start orally and then gradually withdraw the enteral feeding. So that is the principle. Why is it so difficult, man? So why not? Why? What are the cons of not doing a feeding jejunostomy? What are the complications? In other words, do you know types of feeding jejunostomy? I think you
I
should.
think feeding gastrostomy, feeding jejunostomy, you should have a class by itself.
Ade. But anyway, I thought if they know about it.
I don't think anyone has a clue. Feeding gastrostomy, feeding jejunostomy. How will you do? When will you do? How will you manage? What are the expected complications? How do you recognize? Once recognized, how do you manage? Is a class by itself. You must do it.
Okay, we'll do that.
Yeah.
So, but I think homework for all of you: read up about jejunostomy and gastrostomy.
To just to give you few points, like Ravi Shankar said, most of these esophageal cancer patients are cachectic, and so that you can start feeding from the very next day itself. Higher risk of anastomotic leak is when the esophagogastric, unlike the ileal or jejunal anastomosis, you have a little higher incidence of leaks and complications. So even if there is a complication, anastomotic leak, you can maintain the nutrition through the feeding in the feeding jejunostomy. That's the whole idea. Obviously, if you don't do it and you have to put the patient on parenteral nutrition, especially if things go wrong, parenteral nutrition is not just on costly, but higher complications. including infections, thrombosis, and etc. Okay, continue the next slide.
Sameer, go on, man.
Yes, sir. So robotic assisted minimally invasive esophagectomy. It is an advanced form of minimally invasive esophagectomy using robo for both thoracic and abdominal phases. As of for now, it is increasing in adoption in high volume tertiary centers. Um, Advantages. So first, technical, it will have like we'll have the 3D high definition magnified view and 7 degrees of freedom for resisted instruments, tremor filtration, and stable camera platform. Oncologically, it is comparable to the already established procedures and potentially better recurrent laryngeal nerve preservation according to studies, and comparable lymph node harvest has been shown according to trials. Clinically, patients have a lesser blood loss, reduced pulmonary complication, less post-operative pain, and
Samir,
shorter. Yes, sir.
which surgery you're talking about, Robo? Which type of surgery?
You skip this slide and move on, man. It's not for you.
Robotical
Go
are
on, go
not
on.
necessary for DNB.
You should just know that it is robotic.
Yeah, you
Okay.
should know the basics of robotics. That's all.
Go on, go on.
Yes.
Brachyscopic approach, you can tell. Laparoscopic.
So, esophagectomy comes with its post-op complications in mainly the conduit necrosis, wherein if patients will have hemodynamic instability, they can go into sepsis because of leak. Diagnosis is mostly clinical and then aided by CT scan and endoscopy, and they will need urgent surgical exploration. And because we are handling the uh, thoracic duct, so high there are chances of chyle leak, and it can be seen in chest drain outputs, which will show milky fluid, and the same will have higher triglyceride levels. These
No,
patients
no,
can
forget about
initially.
chylothorax. Talk about the anastomotic leak, and that is
Ah,
the most dreaded complication.
anastomotic stricture is not a post-op complication, man. It's a long-term complication.
So the anastomotic leak, what is the dreaded complication of anastomotic leak, man?
Sepsis, sir.
No, that is called something.
Sameer, conduit necrosis is something that you have to recognize on table. It's not a post-op complication. Post-op complication is the anastomotic leak that we are worried about. All others like chylothorax infection, all this is fine. How do you recognize a anastomotic leak?
How
And
is
what
it
is
different when if it is in thorax, if it is in the neck?
Yeah.
How do they present with? And you only said no that time cervical it is easier or less complex.
Okay, somebody else please
Yes.
answer. Ainas or Nikita.
The cervical.
what happens? What is it called? The most dreaded complication.
Where
It is
will the
because of
infection be?
thoracic. It is mediastinitis, sir.
Ah,
That word, mediastinitis. What is the mortality with mediastinitis? Upwards of.
30 to 40%.
You're
higher.
lucky. You're lucky if it is 40%, man. Nikita, anybody plus
Up
Karthik, you
to
are just
50%, sir.
no, even higher.
It
If
will
you
be
don't
higher.
recognize it immediately, it can be much higher. Yeah, okay. That's why you need to recognize it early. What is the first sign of an anastomotic leak is the unexplained tachycardia, tachypnea. Then the fever, then the rise in total count. Post-op day 4, day 5, if you see all these things, you need to suspect the anastomotic leak. First thing that you suspect and rule out. Okay, go on.
Uh, Initially, patients with chylothorax will be managed with fat-free or fat-free and this TPN changes to nutrition, and we can try octreotide to decrease the leak. And finally, thoracic duct ligation can be done in patients who do not respond. Because we are handling so close to the pericardium, and there are expected complications of atrial fibrillation, which can be seen in during ECG monitoring, and patients will have tachyarrhythmia, palpitations. They will be managed by rate or rhythm control and electrolyte correction. And a late post-op complication will be anastomotic stricture, wherein patients will present as progressive dysphagia in a later date, and these can be diagnosed by endoscopy and will require repeated endoscopic balloon dilatation. Finally, delayed gastric emptying. These patients will present as like vomiting, ileus kind of a picture. Um, Again, diagnosis is clinical with radiological aid. Um, we can do endoscopic pyloric dilatation or botulinum injection to relax the pylorus.
See, you have left out one. You said to diagnose anastomotic leak, you use endoscopy. Usually, they don't. They will advocate not to do endoscopy in such patients because there is a danger that you may actually worsen the situation. If it is a small leak, by putting the scope through, the scope may damage and cause and even the insufflation of air can cause. So you generally won't advocate endoscopy. Usually by CT scan is where you diagnose. Contrast, maybe you can give a gastrograph in contrast and prove that there is anastomotic leak. Another important complication you missed is pulmonary complications. Even without anastomotic leak, because you have gone into the chest and things like that, and especially if they have had thoracotomy, their breathing is affected, so they may initially develop atelectasis, later pneumonia and things like that. So pulmonary
It,
complications are quite common, 30 to
it
50%.
was it was one of the major cause of morbidity and mortality,
Yeah.
especially during open era. That is why like everyone was scared to do surgeries for esophagus.
So you have not included that itself. Pulmonary complications. Pneumonia is a very common complication post-operatively. Rajshekar?
Correct, pa. When you are in operating in the upper abdomen or in the chest, that is the most common complication,
Complication.
actually. Atelectasis, pneumonia, empyema. Then comes the others. Anyway, pain management is again a big topic by itself when you are operating in two-field or three-field
Yeah.
dissection surgery, like two surgeries or three surgeries. How will you manage the pain in these patients? How will you manage nutrition? How will you manage with cardiac complications, pulmonary complications? How do you prevent those complications according to the age-wise, based on the preoperative morbidity that they have? Like if the patient is already IHD, hypertensive, dilated cardiac chambers, or pulmonary hypertension, what preoperative optimization will you do? There's a whole list of ifs and buts and discussion. You have made it into only 4 slides. Anyway, go on, continue. Yeah, highlight this.
So, for locally advanced esophageal carcinoma, there are three major trials, which are the CROSS, FLOAT, and ESCORT Neo trial.
No. First you tell what you do and then go for the trials.
He is coming to those details of each trial. Yeah, let him. Yeah.
So for T2 to T4A and node positive esophageal cancers, for squamous cell carcinoma, the preferred strategy will be neoadjuvant chemoradiotherapy And for esophageal adenocarcinoma, it will be neoadjuvant chemotherapy plus or perioperative chemotherapy according to CROSS trial or FLOT4 trial, respectively. CROSS trial was a trial which compared neoadjuvant chemotherapy followed by surgery versus surgery alone in patients with resectable esophageal junction cancers, and it has demonstrated a significant survival benefit of 49 months versus 24 months in and improved the with improved long-term outcomes compared to surgery alone. And this has made cross regimen to be standard tri-modality therapy for esophageal squamous cell carcinoma. Herein, we give chemotherapy drugs, which is carboplatin and paclitaxel, and radiation 41.4 K in 23 fractions for a duration of 5 weeks. This is best suited for mid and upper thoracic squamous cell carcinoma. And then we had the FLOT4 trial, which compared perioperative float chemotherapy in patients with locally advanced resectable gastric or GE junction adenocarcinoma. It showed a median overall survival of 50 months versus 35 months with the prior previous regimen, and a higher 5-year survival rates 45 versus 36%, and a better disease-free survival. In FLOT4 trial, we give 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel 4 cycles pre-op, and this is best suited for distal esophageal junction cancers and GE junction adenocarcinoma. Then we had the major trials of neoadjuvant chemotherapy with immunotherapy, wherein PDL1 inhibitors were studied for first line immunotherapy for patients with squamous cell carcinoma and some patients with esophageal adenocarcinoma. They have been compared with chemo alone or chemo radiotherapy, and they have shown that they have a higher disease-free survival with overall survival. And in checkmate trial, they have compared the nivolumab uh, versus surgery alone, and the attraction 3 trial, escort trial, and jupiter 3 trials are the asian trials, which have again compared pdl1 inhibitors immunotherapy versus chemo, which has shown
Samir,
overall
to make
survival
it easy, Samir,
Sir,
uh,
sir,
you just have to remember this is for squamous cell carcinoma. Many immunotherapies are there, trials are still ongoing. The overall theme is that with addition, there is better outcomes. You can go to the next slide.
Thank you, Swarup, summarizing. Yeah. Next.
yes, sir. So for systemic palliative therapy in squamous cell carcinoma, the first line chemotherapy will be cisplatin with 5-fluorouracil and carboplatin and paclitaxel. For adenocarcinoma, we'll follow the FOLFOX or CAPOX regimen and cisplatin with 5-fluorouracil. And uh, as we have already discussed, esophageal adenocarcinoma have HER2. You can go for HER2 targeted therapy with trastuzumab. And in these patients with squamous cell carcinoma, we have a first-line immunotherapy with nivolumab and pembrolizumab, which are PDL1 inhibitors. And second-line chemotherapy will be with paclitaxel, docetaxel, and irinotecan. In esophageal adenocarcinoma, addition of uh, ramucirumab, which is a VEGF inhibitor, and docetaxel can be done. We have targeted biomarkers, which I have discussed, which is PDL1 for squamous cell carcinoma. For esophageal adenocarcinoma, we have HER2 targeted therapy, MSI, and Claudin protein.
Samir, have you really done these slides by yourself?
Sir? Yes,
Have
sir.
you done these slides? Have you really gone through all these trials and read
Sir,
all
in a
these
brief,
trials, details?
not details, sir, but brief, because yes, last class
What
Okay.
sir
immunotherapy.
is asking is, have you done this table by yourself, or you pasted, taken it from somewhere and put it here?
No, sir.
Not AI generated, no?
This is actually a wrong information is there. There is no regimen where you use nivolumab plus pembrolizumab. They're competing products of the same type, like drinking Pepsi plus Coca-Cola together in the same glass.
Moment
You
I
won't
saw that
do the
slide, that's
same
why I
job.
asked him, where did you get these slides from?
So also this paclitaxel, docetaxel plus irinotecan triple regimen nobody uses. It's very toxic.
Irinotecan is very toxic.
Yes, yes.
Skip this
But
slide.
again, to summarize this, I'll just
Yeah.
summarize this slide, sir.
Yeah.
If you look at squamous cell carcinomas, immunotherapy is coming up in a big way. But
Yeah.
when you go for adenocarcinoma, you have to look at one thing. If HER2 positive is there, in breast cancer, you see so many people HER2 positive. 18 to 20% of esophageal adenocarcinomas have a probability of having HER2 positivity. For them, trastuzumab comes into picture. And then MSI, microsatellite instability, just like you've seen in rectal cancers, recently you read about it, colon cancers. In esophageal cancer also you can get MSI high tumors. For them, you can use immunotherapy. That's it.
Yeah. I think
No,
that is
Saurabh, this is for
Generally,
palliative or this is for as a treatment, like curative immunotherapy.
So this particular slide is for palliative, but it also applies for locally advanced.
okay, next slide, Sameer. Yeah.
For patients with intent of palliation in advanced unresectable metastatic disease with a fairly okay ECOG status, and these patients are fit for systemic therapy, we can try systemic chemotherapy plus immunotherapy. For patients who have a poor performance status, best will be
Sameer,
only.
hold on. What do you mean by ECOG status? Correct description. We will end the class. You are
Sir,
said,
ECOG,
written it in
ECOG
2-3 slides, ECOG 0 to 2, more than 3. What do you understand by that terminology? What do you mean by that?
Sir, ECOG will be to see the general condition of the patient, sir. Zero will
Expand
be.
that. What does the ECOG
What
stand
is
for?
ECOG? 0, 1, 2, 3. What?
Somebody from the others,
East,
seniors?
Eastern Cop, this one, Eastern
Eastern
Cooperative Oncology
Cooperative
Group.
Oncology Group, sir.
It is a
Okay.
performance status, sir.
What is class 0, class 1, class 2, class
Zero will
3?
be fully active patient, sir. He will be like a patient who are able to carry their all activities without any restriction. One will be they will be able to carry with the restrictions with some like physically strenuous work they can't do. Two will be ambulatory and but they are not able to carry out all activities like some 50% they will be
Okay,
there.
you must have a precise definition of what is this and how do you classify into 0 to 4. It's your exam question. Okay, next, continue.
Is four will be completely disabled, sir.
Yeah.
Cannot carry, yes, and five for patients who are dead.
And don't go on, man. Stop.
So what is the equivalent of ECOG in non-malignant patients?
Karnofsky status.
Karnofsky. Yeah, Karnofsky scoring for non-malignancy
Why are you
ECOG.
in doubt, man? You're answering like very low assets.
Okay, carry on. So poor is a performance state, best supportive care.
Yes, sir.
Swaroop, just
For poor.
summarize the palliative part, please.
Okay. So many people who may present at advanced stage, some people may progress into advanced stage. They may require palliative care. So most of these patients go into nutritional compromise and they become sick, and as a result, they may also end up with aspiration pneumonitis and all those things. Rarely people may even present with esophageal fistula. That is a very bad thing to have. Nutrition is compromised, airway is also compromised, and they have pneumonia and all those things. So otherwise, palliation is more of symptom relief. Some people may require some pain management, oxygen relief, total parenteral nutrition, and this is where your feeding jejunostomy also comes into picture. Stenting, self-expanding metal stent. That is one thing which should be very often considered. Like somebody is 85-year-old with multiple cardiac comorbidities will not do either surgery, chemotherapy, and all those things. A SEMS placement will give them good amount of nutrition, and they live for a good amount of time with good quality of life. So you should be knowing about SEMS placement. What is the meaning of self-expanding metal stent? Why is it called as SEMS? What are the problems also with the SEMS? What will happen if it migrates? What are the risks of placing it? And then about management of tracheoesophageal fistula. If it has already happened, how do you see what imaging do you do? And if you find a small TUF, do you try and close it? If yes, how? This tool has what do you do? So these points you should know, Samir.
So the palliation will be one, to allow the patient to eat as much as possible, two, to make them pain free, and three, prevent the manageable complications like pneumonia, and four, worry about nutrition. I think that is the one, those are the four things you need to worry, think about when you're thinking about palliation for esophageal malignancies. It used to be said that you don't do a gastrostomy or a percutaneous gastrostomy in patients with esophageal malignancy, because you are just unnecessarily prolonging their life with no quality of life. This was said in Bailey and Love long time ago. I think that still holds good.
Next, Sameer. This you please read it. Covered, uncovered, how will you retrieve, how will you position it, whether you use a C-arm or direct vision. If it displaces, what will you do? How will you make sure it remains in one place? There's a whole host of questions about it. Next.
So, we also have palliative cryotherapy, which can be tried in patients who have severe dysphagia. Herein, we can increase the lumen can be widened, sir, after cryotherapy.
Yeah.
Rarely used, man. Why do you have to use cryotherapy when you have self-expanding metallic stents, which will increase the lumen and also press the tumor against the wall so that it will allow the patient to eat.
Cryo is more used in the airways to debulk the tumor so that patient can breathe better.
Usually, cryo is used when there is bleeding also from tumors.
Yeah.
We have to control.
This slide, skip it. It's not for you guys. Okay, next.
That's it.
Okay, you come to the end.
This slide is for all of us.
Yeah, it's a half-hearted preparation, Sameer, if you ask me.
Yeah.
Sorry to say that. Yeah. Anyway, good.
Any other questions, anybody?
Okay, if you have no questions, bye. Good night.
Srikanth, your views?
Yeah.
Okay, but you should have read more and then presented
No,
more fluently.
it's
Basics you
not a
should
topic that
concentrate.
they can understand easily.
That's what
I
I'm
get
telling
that
you.
point. Yeah, so that's why there is a lot of hesitation in him, what to say, how to say, anta heli. That's fine. Yeah.
You read more about basics and not about all this advanced all those things.
Yeah. Okay. Good night, guys.
So yeah, thank you, Niranjan. Thank you very much, and Swaroop.
Thank you, sir. Thank you.
Srikanth, thank you.
Sameer, you're like just like last class. This class was also like not well prepared, and you're still struggling.
It is a tough topic, we know,
Anyway,
but we need to prepare better. That's all.
see for next classes. Okay then. If there are no more questions. Good night, sir. Thank you, everyone.